Non-operative rehab of knee osteoarthritis. What's going on, guys? This is Dan Pope and Kevin Coughlin. We are physical therapists. We work at Champion PT and Performance. We have done yet another literature review on a very exciting topic today, knee osteoarthritis. We're going to share what we found, and hopefully you learn a little bit. What's going on, Kevin?
Not much. I thought this would be a good topic here because no matter what setting you work in, like sports or outpatient orthopedic, it's something that you'll definitely see a lot of. I think just in relation to what you were talking about in our previous episode, this is so prevalent and there's so many knee replacements being done and at younger and younger ages that there is a good place for non-operative rehab, whether it's to delay a knee replacement or to avoid a knee replacement. And there's some good evidence on what we can and can't intervene with. So excited to kind of share this stuff.
Me too. Let's share.
All right. So just a little overview of what we'll talk about. Is there evidence that non-op rehab works for knee OA? The struggle of putting some of the research into practice. I'm going to highlight a study and then summarize some of the best practices based on that study and how we can incorporate all that stuff into a PT rehab session.
Can't wait.
Sweet. All right. So first, just broadly, is non-op rehab effective for knee OA? So we all the time like to think that we can help with these patients, but where does that thought that we can help come from? And there was a lot of studies out there showing that non-op rehab is effective, and just some of the things they talked about here. So a lot of the studies, when they're trying to determine effectiveness, they'll look at studies that reported on pain, they reported on function, whether it's different scales like the KOOS or something similar. They reported on quality of life and sick time from work or days missed from work. So they look at all these things and determine what affected non-op rehab have. And just some highlights and quotes from the studies here is that it is well established that physical activity and exercise therapy reduce symptoms and improve physical functions in individuals with knee OA. Many types of exercise have been shown to be helpful, and that's something we'll talk about a little later when we get into the rehab design. But you can really work with the person in front of you and their specific activities of interest, because a lot of things are going to be helpful. So if they like to swim, that's going to be pretty good. If they like to cycle, we can make that work. If they like to strength train, we can make that work. There's so many different avenues here, and any exercise is going to be better than not exercising. I will say that there are some studies that specifically seem to show that quad strengthening is helpful for managing knee symptoms in these patients. So it's always confusing to me because we don't think necessarily that weakness causes arthritis, but we know that quad strengthening specifically above some other types of strengthening helps arthritis in the knee. So what the mechanism is there. And I would think that we could use our best judgment if we're trying to design like a program to help prevent this type of knee pain. It would include quad strengthening. So, but that's specifically mentioned in these studies is quad strengthening. So I think important to keep that in the programs.
Excusez-moi, but I've got something pretty juicy for you. Boom. It's an evidence-based guide to knee osteoarthritis. Uncle Arthur comes for all of us over the course of time, and for your patients, it's no different. But if you've got this cheat sheet, then you'll be ready. Let's face it, nobody has time to stay on top of all the papers coming out on a regular basis to make you a really good coach and clinician. Luckily, you have psychopaths like me who love reading through this stuff, summarizing it, and putting it into a nice little cheat sheet. And my promise to you is I'm going to catch you up on the latest research in under 10 minutes. We go over prevalence, weight loss, risk factors, whether or not competing in a sport increases rates of osteoarthritis, and whether or not strength training slows down the rate of arthritis. We go over pathophysiology, clinical presentation, diagnosis, rehabilitation, and management. Best of all, this thing is 100% free. I'll leave a link in the description below. Go ahead and click on that and get up to date on your favorite knee injury, good old arthritis. Now, back to your learning.
And continuing with these studies that was just looking at the effectiveness, I include some of these quotes because I do think it's important and interesting from the study. So without trying to be too wordy, what they were saying is Methodologically rigorous international guidelines strongly recommend non-pharmacological strategies as the first line treatment for knee OA. So that's us as physical therapists. That's the first line treatment, which I think is pretty good. Exercise, patient education, and weight loss when needed are the recommended first line strategies to manage symptoms of these patients. So those are all places we can intervene, which I think is awesome. There's high quality evidence demonstrating the effectiveness of education and exercise to improve function in individuals with knee OA. And current clinical practice guidelines recommend education and self management, exercise, and weight loss for those who are obese or overweight as first line treatment. So, see here from a couple different sources the importance and the relevance of what we can do as PTs to work with these folks. So, I thought this was pretty good here. This was a clinical trial, and this is it's titled "Good Life with Osteoarthritis in Denmark." So, a study out of Denmark. It looks like the GLAD study, which is pretty cool. And it's evidence-based education and supervised neuromuscular exercise delivered by certified physiotherapists nationwide. So, the Good Life group was established in 2013, and their aim was implementing evidence-based guidelines. So all the physiotherapists in that nation were doing similar care. They didn't want you to go to 20 different physios and get 20 different treatments. They were really trying to standardize the care there with the best practice guidelines. And what they did was they would educate these clinicians for 2 days on a educational program to make sure they were all up to par here with their treatment. So that's a little background about that group. And then in terms of the trial design, they used data from 9,825 patients, so a pretty good N there. And they did include hip and knee osteoarthritis. There were more patients with knee osteoarthritis. It's the more common of the two in terms of incidence and prevalence. So the number was a lot higher for knee OA, but hip OA was also included. And the intervention, it was 6 weeks long, and there were 3 sessions of patient education delivered over the course of the first 2 weeks. And then there were 12 sessions of neuromuscular exercises delivered twice per week. And what they found at the end of this, when they were going by some of the best guidelines, is it had beneficial effects on knee OA and hip OA symptoms, on physical function, on medication intake, and sick leave time. So they were missing less work, their function was improving, their symptoms were improving, and they were taking less medication to manage their symptoms. So I think that's a pretty big win there and pretty cool. I didn't see anywhere in the study, they didn't really talk about why they chose neuromuscular over other types of exercises, but that's okay. And I think the second part of this trial, which I thought was really cool, is after the intervention period, they measured outcomes at 3 months. So that was the end of the 12 weeks, and at 12 months. So they were looking at this kind of short and long term after the study had ended. Did these folks maintain an improvement in their function? And the outcomes they were looking at, if we're thinking about the sick work time is one of them, but then we're thinking about pain and function. So they used the VAS pain intensity, a 30-second chair stand test. So like a sit to stand test over 30 seconds, counting repetitions, 40 meters of a fast paced walking test, physical activity. So number of days per week being physically active for at least 30 minutes, the quality of life section of the KOOS, and the quality of life scale from 0 to 100. And then they wanted to also figure out the number of patients that were taking narcotics or had a sick leave time from work. So they're kind of evaluating a lot of different facets here. And they saw an improvement in all these things. And then interestingly, they said, furthermore, some beneficial effects introduced by the interventions, including increased physical activity and quality of life, were maintained 1 year after the conclusion of the study. So I think that's awesome. You know, with this type of educational approach and intervention approach, we saw that there were short-term improvements and there were long-term improvements. But I think interesting here towards the end of the paper, the authors say, unfortunately, we have a good understanding of what non-operative treatments work, but recommendations are often not followed by healthcare providers. So that was their goal, is how do we get all these providers on the same page? But then they talk about a couple things here. So these are a couple quotes from this paper. So, however, despite the evidence, physical activity and exercise are underprescribed in the treatment of chronic diseases, resulting in suboptimal care, including osteoarthritis. This is also true for OA. So yeah, despite strong evidence from more than 50 randomized controlled trials in knee osteoarthritis and 10 randomized controlled trials on hip osteoarthritis, because both were included in the study, supporting the efficacy of exercise, the uptake of exercise, education, and weight loss as first-line treatment for patients with painful knee and hip OA is suboptimal in clinical practice. A recent systematic review demonstrated that only 36% of patients with OA received appropriate non-pharmacological care according to the guidelines. So yeah, it's a bummer. I mean, we have good education and evidence out there. We know what works for these folks, but in Denmark, and I'm sure it's not too different here, I think it's probably a worldwide issue, is that we have a problem implementing it and getting the knowledge out to physical therapists on what type of care in doctors, because doctors might, we definitely have orthopedics who patients go and see. And if they hadn't been to physical therapy before, they don't think of going, but the doc might just say, stop running, take up swimming or something like that. And there's not a whole ton of guidance. So I think it's encouraging that we can get good outcomes with this, but we need to do a better job educating doctors and patients that we can help here, and that there are good options, and we need to do more consistent treatment as a profession.
Mm-hmm. I always thought, this was like years ago when I worked in a standard outpatient, I saw so many joint replacements, but it was very uncommon to actually see folks had knee osteoarthritis prior to replacement. And I think now working at Champion, which is a sports PT setting, we're out of network providers. So we tend to see folks that maybe are a little bit more skeptical of different providers and they want like a higher level of care. So they may go see us over somewhere else. But I think I tend to see slightly more folks that have knee arthritis that want to try more conservative care prior to knee replacements. But one of the things I hear a lot that does bug me a little bit, and I think it's just silly, is that folks will go to a surgeon and they'll say, hey, my knee hurts, right? And they'll order some imaging and they'll bend the knee a little bit, do a clinical examination, like, yep, you got arthritis. Come see me when you can't take it anymore and need to get surgery. And I just feel like that's such a disservice to the patient, because there's definitely a lot you can do, even if they do have advanced osteoarthritis, to try to reduce pain and improve function. They're always just like a big head scratcher. It's like, why don't you just refer for some physical? Because I can't tell you how many patients we see with like patellofemoral pain, patellar tendinopathy, quad tendinopathy, like all these things can be helped with physical therapy, but knee osteoarthritis is like, whoa, we can't. Sorry. See me when you need a joint replacement. It's like, whoa.
Yeah.
So hopefully that information does get out there a little more. And I often will see patients with knee OA when they come to see me and they don't know what's going on. We're like, I think you have some arthritis. We can help you with that, right? When they get to the physician first, I think oftentimes they just don't come see us because the advice is to wait, to go as long as you can. And I don't know. I'm not sure why that exists, but to your point, A, we might not be doing a good job as PTs, right? Doing the right things. But B, I think we're not getting the right folks from docs to PTs so we can do the right thing, right? I don't know.
Yeah. And I would think these aren't people that need extensive PT. They just need good education on like what they should and shouldn't be doing. And we'll get into this when we talk about joint replacements a little bit, but whether they start PT as soon as possible is a win-win, because pre-op, we know that it's going to help their outcome if they do have a knee replacement, or it's going to delay the need for a knee replacement. And we know that there are revision rates after the first and especially the second decade of having a knee replacement. So if you have someone in their mid 50s with bad arthritis, that's a person we can really help a ton, hopefully delay their knee replacement until they're in their mid to late 60s. And then they don't need to ever get another one. Perhaps that's the only one they'll need. So there's good reason to do this, whether you're going to get surgery or not, because it's going to help pre-op and it could delay when you need it. And then you get better life out of it. So I think it's really important that we do these things that the authors in this trial had their physios do. All right. Another study here. And this was really good. So this is from the American Academy of Orthopedic Surgeons. And this is their clinical practice guideline summary for the management of knee osteoarthritis for non-op. So kind of what are the orthopedic surgeons doing here? This table here is, and if you look at the paper, this is kind of like, I think about our clinical practice guidelines from JOSPT. And usually it gives you a summary of the evidence and what the different evidence recommendations are. So in their vernacular, they're kind of using this visual star system, which I think is kind of cool. And the table has strength from strong to moderate to limited to consensus-based evidence. And then there's a little bit of description of the evidence. So what they're calling strong evidence is that it's evidence from 2 or more high quality studies with consistent findings for recommending for or against an intervention, or the recommendation is upgraded from moderate from the previous edition. What they're calling moderate evidence is evidence from 2 or more moderate quality studies with consistent findings, or evidence from a single high quality study for recommending for or against an intervention. Limited evidence is evidence from 1 or more low quality studies with consistent findings, or evidence from a single moderate quality study. And they talk about what these types of studies are in the paper. So you could definitely look at that. And then a consensus-based recommendation is that there's no supporting evidence or high quality evidence was downgraded due to major concerns addressed in the framework. In the absence of reliable evidence, the guideline work group is making a recommendation based on their clinical opinion. So I think that's important to keep in mind when you look at these. They kind of remind me of our JOSPT A through E recommendations. And then just what they're saying here is based on the strength of the recommendation that we'll get into for the different interventions they talk about is, how to think about these things. So strong recommendation is the least time counseling the patient. These are things that we know are going to work. And just, spoiler alert, this would be like where exercise is a strong recommendation. So it's not likely to change with future research. We're pretty confident in this recommendation right now is what they're saying. With a moderate strength of recommendation, it takes a little more time to educate the patient about, and we're less likely to change the recommendation in the future because there's a fair amount of evidence to support this recommendation. With limited, you have to educate the patient because we don't have a ton of information. So you're kind of telling them, hey, like, here are the pros and cons of this thing. We've tried all the strong recommendations first. Now let's get into this one. And like I said, here's the cost benefit analysis. And this could change in the future as more evidence comes out. And same thing there for consensus statements. So keeping these in mind as we go over the levels of recommendations, I think are important. It's not the be all end all, but I think the orthopedics here have good recommendations that we'll get into.
Yeah, I think that was smart because we talked about this in prior episodes, but sometimes a study will come out and it's maybe an underpowered study and there's just one of them, right? And then another study comes out that like says the opposite, right? And you may be the clinician where you saw the first study and you're like, I'm changing my entire practice. And the second study comes out and you're just left confused, right? What's at least nice about these guidelines is that they're basically saying that there's enough high quality research that you don't have to second guess your treatment, right? For the others, maybe we're a little bit more skeptical, but I guess I just appreciate that the authors use that as one of the ways of measuring the strength of evidence, right? It's pretty cool. And I'm glad to see that strength is in there, exercise is in there. That's good stuff.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
All right. So now going through the specific things, and I always like these guidelines because, like you and I, Dan, go through all the research to make these PowerPoints and try to make it as detailed as possible. But I think for busy clinicians, looking at these guidelines is just a really kind of like cheat code where the authors are really, really smart people that have gone through the research and distilled some of the most important things. So when available, I always like these, like in the PT world, we have them and they have them here that, I think these particular guidelines were actually endorsed by the APTA for treatment of knee osteoarthritis. So, it is a pretty good stuff when available. So in the category of strong evidence, so again, these are practitioners should follow these recommendations unless a clear and compelling rationale for an alternative approach is presented. But like I had mentioned for the strong evidence things, these are unlikely to change. So they're saying that lateral wedge insoles are not recommended for patients with knee osteoarthritis. So they make some positive recommendations and then some recommendations against. And I think they're saying here that it's just kind of a waste of money. I think more and more studies have shown these to not be helpful in patients. And it used to be something that was recommended often. So they wanted to put here that with strong evidence that we shouldn't recommend those. Topical treatments, such as topical NSAIDs, something like voltaren or something like that, should be used to improve function and quality of life for the treatment of OA of the knee when not contraindicated. So like Dan had talked about a lot on the osteoarthritis podcast previously, this is primarily an inflammatory condition. So NSAIDs do really seem to be helpful for these folks. They don't need to be on narcotics. We'll get into that, but that's a evidence against type thing. But NSAIDs are kind of a green light when managed appropriately. I think with a physician's guidance is going to be good. And topical, keep that in mind because it's, that's a different delivery mechanism that might be more helpful than oral. So you could talk to your orthopedic about that, but that's a possibility. And then our favorite, so supervised exercise, which was recommended over unsupervised, but supervised, unsupervised, and or aquatic are recommended over no exercise to improve function for the treatment of knee OA. So that's important as well. And then you can continue there. Further strong evidence recommendations. So patient education, that's likely to be, that's a strong recommendation, something we should do for these patients, educating to continue to be active, educating to, have a healthy diet and other things we'll talk about. Oral NSAIDs are also recommended. So we said topical, but oral as well. Acetaminophen is recommended to improve joint pain. And then oral narcotics, including tramadol, result in notable increase of adverse events and are not effective at improving pain or function for the treatment of OA of the knee. So good to know there that we shouldn't be promoting those. But if someone wants to take some NSAIDs or they've had success with voltaren, that's great. And then we combine that with exercise. And I think we're covering our bases for some of the strong evidence things.
Strong evidence favoring oral narcotics, increasing adverse events. Always good to know.
Definitely. Yeah. I can't imagine it doesn't help with pain, but definitely probably doesn't help with function. So
there we go.
Anyway, yeah. And then getting into some of the moderate evidence recommendations. So just to highlight that again, practitioners should generally follow a moderate evidence recommendation, but remain alert to new information and be sensitive to patient preferences. So I think in the strong category, we should be educating and doing most of those things with our patients. And then here we probably could follow most of these things and then work with the patient on specifics. So canes, using a walking cane, it can help improve pain and function in patients with knee OA. So, I've definitely seen patients where when they're in a pretty bad flare up and their knee feels crappy, walking with a cane might feel a little bit better. So maybe if they know they're going away for a long period of time, they're going to be doing a long bout of walking, bring the cane with you and you can offload a little bit when you need to. Could be helpful. There are different types of braces that could be used to improve function and pain and quality of life. I think specifically offloading braces. So some patients have a little more, say medial knee osteoarthritis. That type of brace might give them some symptom relief. And if they've had success with a brace in the past, I don't think there's any reason that we would say don't use a brace. So keep that in mind that has moderate evidence to support. Neuromuscular training. So balance, agility, coordination type things in combination with regular strength exercise can be used to improve performance and function, and walking speed for the treatment of knee osteoarthritis. And then weight loss. I think this will depend on the patient and good metabolic health, but sustained weight loss is recommended to improve pain and function in overweight and obese patients with knee osteoarthritis. So some good stuff there. Continuing with moderate evidence, hyaluronic acid intra-articular injections is no longer recommended for routine use in the treatment of symptomatic OA. So I think that's important and interesting thing to keep in mind because I know we used to hear that a lot. Intra-articular corticosteroids, they can improve short-term relief for patients with symptomatic OA of the knee. Lavage or debridement in patients with a primary diagnosis of knee OA is not recommended. I guess there we might be seeing more tissue damage and over time things get a little bit worse. But yep, moderate evidence, so could be open to change long-term. And partial meniscectomy, I guess if you're already at the point where you have pretty bad arthritis and you're having some mechanical symptoms, perhaps that's related to the meniscus. So they're saying arthroscopic partial meniscectomy can be used for the treatment of meniscal tears in patients with concomitant mild to moderate OA who have already failed PT or other non-surgical treatments. So I like that they added that. You still want to try PT first, but if you're not getting the symptom resolution you want and you have mild to moderate arthritis, we can consider a partial meniscectomy for those folks in the rehab process. So good to keep in mind with that.
Yeah, I'm glad that they kind of mentioned that too. And I think we have had a bunch of patients like that essentially we're always trying to avoid the meniscectomy if we can. But some folks, they go for a long period of time, they do all the right things, and they're still having a lot of symptoms associated with it. So I do see where the meniscectomy can be helpful for those folks, but the other problem is that can lead to more longer term osteoarthritis. So we're always trying to be conservative if possible, but that does make sense.
And then just getting into some of the things with limited evidence. So again, practitioners and PTs should feel little constraint in following recommended labeled limit, the recommendation labeled limited. We should use our clinical judgment and be alert for emerging evidence that clarifies or helps to determine the balance between the potential harms and benefits. And overall, patient preference should have a substantial influencing role. So in terms of oral or dietary supplements, at least the ones that they talked about in this paper, the following supplements may be helpful in reducing pain and improving function for patients with mild to moderate knee OA. However, the evidence is a little inconsistent and limited, and we probably need more research. And they talked about turmeric, ginger, glucosamine, chondroitin, and vitamin D. I guess I would think of that, if the patient was coming to me and they're exercising, they have a brace for when things are really painful. They're very healthy BMI, and they're really taking care to do everything. And they're asking if they could take a turmeric or ginger supplement. I would probably say that it's not harmful to take, and it may help. And if you've had success with it in the past, you could probably keep taking it. But just be on the lookout for that, because people ask about those things a lot. And again, I think the limited evidence here doesn't mean it doesn't work. It just means let's be on the lookout for a little more information. Manual therapy, in addition to exercise, may be used to improve pain and function in patients with knee OA. I think anecdotally, it does seem to be kind of helpful, but it's obviously not the long-term solution. Laser treatment, so more and more clinics are getting these, may be helpful, limited evidence. And same thing with acupuncture. So not a ton of evidence for these things, but I think they're on the table if we're kind of doing everything else that we need to be doing.
Yeah, really interesting. What I will say is I do try sometimes to point these patients towards supplements. I always am wary of supplements. I think supplements are exactly what they say they are. They're to supplement whatever else you're currently doing. But yeah, I know that there's plenty of papers I've looked at that turmeric, ginger, vitamin D, helpful. The other one I will recommend sometimes, I've looked up the name because I always forget it, but it's Boswellia serratia. I think I'm saying that right. But there are some decent papers show the efficacy of that. So I will mention those supplements to my patients, but I think the big thing is make sure they're doing all the low hanging fruit first. And then I just don't like to withhold any information about things that could potentially help. So, because a lot of times these folks are trying anything and everything, and they're having a lot of trouble. So that is one of the things you can recommend, but obviously refer to a nutritionist that understands these things if someone really wants to get expert advice on how to implement them. But just easy things to recommend to your patients sometimes.
Yeah, and I think a fair point there is that a fair amount of patients don't want to take NSAIDs because they come with other side effects. So if you want to start with some of these supplements, it seems like that's okay. There's nothing wrong with that. And then if they're not working for the pain management, move on to an NSAID or something like that. So yeah. And then just things with limited evidence. So practitioners should feel a little constraint. Okay, so yeah, same thing here as before, same category. So TENS, modalities to improve pain, TENS, limited evidence that it may or may not help. Some patients love it. They can continue to use it. But again, I think all these things come under the umbrella of things we try after we've done the most important things that we know to do with these groups of patients. So TENS, shockwave therapy, PRP injections, which I think, may change as there's more and more studies and evidence going into that, a denervation therapy, and a tibial osteotomy. So high tibial osteotomy may be considered to improve pain and function in properly indicated patients with unicompartmental knee OA. And that's something I'm sure we'll talk about more in the future. But I think the properly indicated patient there that they're talking about is probably a younger patient who's trying to avoid getting an early knee replacement where we know the longevity might not last a full lifespan. But again, these are not things to totally avoid, but things to put after your primary treatments and things to be on the lookout for more evidence emerging in the future. So I think pretty good list there.
Mm-hmm. Yeah, I was just going to mention a few things I found. We're not going to go in depth, but to be newer forms of treatment are the mesenchymal stem cells, fat-derived stem cells, bone-derived stem cells. Research is in infancy, but a few studies to show that might be beneficial. The other one that I've seen poking around a little bit, my wife was actually the first person to ask me about this, but genicular artery embolism. You heard of that at all?
Like so recently, it's funny you mentioned that. Yeah. I
Yeah,
don't know if
that's
I heard
another
it. Maybe
very
I heard it
recent
from
one.
you.
Oh, did it? Yeah. But anyway, I looked into it a little bit more. So I've never seen it, but my wife was asking me about it. And I had to look it up some, but apparently it's what it sounds like. So they basically go in the genicular artery and they embolize it so that you're not getting blood flow to certain parts of the knee. And in the last episode, we talked about how there's neovascularization, there's increased nerve growth. We're basically shutting that down. And some of the research is showing that it seems to be beneficial. We'll see what happens over the course of time, but I know that some folks maybe ask about those things, and it seems like they may be effective, but they're in their infancy of research. So time will probably tell. So just some cool stuff that I found.
Yeah. All right. And then their final category here is lack of reliable evidence. So, in the absence of reliable evidence, practitioners should remain alert to new information because emerging studies may change this recommendation. So, it's not totally banning them, but let's just be on the lookout and use your clinical judgment and expertise and patient preferences. So, dry needling. It's the opinion of the group that dry needling, the efficacy is unclear and requires additional evidence. And then same for free floating interpositional devices, which I guess is something they used to use a little more to manage pain. And some folks come in and they like dry needling. They've had it in the past, and there's probably nothing wrong with doing that. But I think thinking you need to dry needle these patients is not right either. So just be on the lookout for more evidence there. But I think that was a pretty good list by them. So that kind of concludes those recommendations. Another paper here that I think will help kind of piece everything together is when we say working with the patient to get their preferences. We talked about this a little in a previous episode, but patients with arthritis often have poor beliefs. They know people who have had arthritis and it's been debilitating. They are afraid to do certain things because they think they're going to make their joint health worse. I mean, I like to run for kind of recreational fitness, and I'll definitely have people ask me often, like, aren't you afraid you're going to need a knee replacement someday? Like my dad specifically says that all the time. He's like, wait till you're my age, you can't run anymore. But yeah, it's funny. So you hear these things, and this is where I think we can intervene. So this paper was just looking at gathering different clinician and different patient beliefs around arthritis and kind of seeing how there's a big difference between thinking about the impairments thinking about it through an impairment-based lens versus a participation-based lens. So we'll get into this a little with this. So kind of long quote here, but I think it kind of is important background on the paper. So this is from the paper. It says, beliefs about osteoarthritis often focus on joint degradation and inevitable progression. These impairment-focused fatalistic beliefs can result in reduced offer of or engagement in active management strategies. Alternative views focus on health as part of a dynamic ecosystem where people are healthy when they can participate in activities they value. These beliefs are associated with increased engagement in self-management and lifestyle-based interventions. Clinician actions that support people to make sense of OA in ways that align with helpful behaviors and support participation in valued activities represent key opportunities to improve health and well-being. So it's kind of on us to do that. So this table here was taken from, or this image was taken from the study. And it's just showing there, I'll explain it if you're not able to watch, but there's 4 corners here, and it's the beliefs of the person with OA, beliefs of the clinician, the impact on clinical care, and the impact on person with osteoarthritis. And this is an impairment-focused belief system. So some of the things that these patients would say when polled is that their beliefs are osteoarthritis is just a normal part of aging. They don't feel heard. They feel like they're suffering in silence. They feel like their joints wear worse with continued use. They have an association with pain equaling more tissue damage or joint damage, and that they think their osteoarthritis will only get worse and exercise can't help. And they often think it can be harmful. And this leads them to kind of resign and withdraw from the activities they like to do. They reduce their physical activity because they associate that mechanical impact with worsening pain and function. They try to protect their joint. They're distressed, and they're kind of withholding. And then if the clinician is focused on impairments, they see it as a normal part of their patients' lives, and it's not too serious. It's something that we see all the time. It's not that big of a deal. When we know what we just said, the patients, it is a big deal. It is a kind of a life-changing thing for a lot of them. We see it as symptoms being due to a change in the joint. And for some PTs, hopefully not the ones listening to this, but joint replacement is the only cure. And there is still that belief among clinicians that increased pain indicates increased damage, and exercise can damage joints as well. There are clinicians that think that and, tell their patients not to run or be careful with those types of impact activities. And the impact on the clinical care is that there's just fear and increased symptoms. There's reduced prescription of exercise, which we know if we want to make the person kind of holistically healthy, that's going to be a negative if they're not exercising. And we're focusing on passive and palliative treatments to get them better instead of what we talked about will make them better based on the best available evidence. And there's a failure to diagnose and minimize and downplay the patient and what they're feeling. So the impairment focus is something that we can't be focused on. So on the next slide there, Dan, they talk about this participation focus. So if you're not able to see this, just this four corners is the same. So how does the person with osteoarthritis, if the focus is on participation, what they can do, and a little bit more of a narrative that's in line with the evidence, how do they think about their osteoarthritis? So they start to see that exercise is good for their joints and for their health. They feel confident to use their joint despite pain because they don't associate pain with worsening arthritis all the time. They can improve their symptoms and impact. Their physical, mental, and social well-being are better because they're doing the activities that they like. Their health is taking part in activities that they value, and their life gets richer as they age. So I think those are really cool beliefs to hear from those patients. And then the impact it has on the person is they're more engaged, they're increasing physical activity, they're participating in activities that they care about, they're increasing their functional capacity. The clinician that looks at the treatment of OA through a participation-focused lens sees that the OA patient is somebody that we can help and intervene on, and that joint replacement isn't the only intervention. We see that it affects the whole person, and we're not just focused on the impairments of the knee, but all those things that the patient's believing and what they can and can't do and how much that matters to them in their life. And that their symptoms are influenced by modifiable factors. And then the impact this has on clinical care is that we're increasing our exercise prescription as PTs. We're considering the whole person. We're increasing the activity in their life. We're listening to and validating their problem. And we're recognizing like the global impact that OA has on the person and the society, and try to play our role in making them more active in focusing on what they can do and providing good education on the things that can help. So I thought that was really cool by the authors here to kind of get that information from patients and see, what are the belief systems in patients that are having fairly good outcomes versus those that are so focused on the impairment and it's, kind of ruining everything in a way.
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up. It's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain Free Insiders. It's $1 for 1 week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
Yeah, I think that's a really good reminder. And I do think that's one of the problems. Sometimes I'm guilty of this as well, but we just know that there's so many asymptomatic findings, right? So osteoarthritis is definitely one of those things. And it's not really fair to the patient, because when a patient comes in and their knee hurts and they have osteoarthritis, we can say, hey, a lot of folks have osteoarthritis. Sometimes they don't hurt. Not a big deal. It's like, well, my knee hurts and it is a big deal to me. I think what we're trying to do is downplay the situation slightly so the patient's not so freaked out about it, but they don't really feel heard with the impairments and the severity of what they're going through, right? And it's also a little bit helpful for when I just saw, just as a reminder, to say, hey, we can do a lot of positive things for these patients, but you have to change their way of thinking first. If they believe that this is just going to get worse over the course of time with activity, when we tell them to exercise more, they're going to be very fearful of that, right? We have to kind of explain that, no, mechanical load is one of the best things you can do for your joint. If there's anything that we can do to improve this situation, it's mechanical loading. And if you stay away from your activities, you're just going to get sicker. You're just going to get more upset. You're going to have all of the negative associations that people see with osteoarthritis. So we probably have to make sure we address these beliefs by potentially asking those questions early on, or at least just getting a flavor of how people react as we start probing and prodding at them when we educate, right? So I think sometimes we get an idea of the type of behavior that these individuals have. Once we start to educate them and exercise them, you can see, are they fearful? Do they have poor beliefs? And they're just really trying to intervene when appropriate.
Okay, so yeah, if we're thinking about how to put all this together in a treatment, or what things to really focus on that we can intervene on as PTs, is that whole education aspect that we just talked about. And then exercise. We talked about that, how there's strong evidence that we should be exercising with these patients. And it's a feasible and effective way for anyone with all severity levels of knee OA, even those with moderate to severe OA, eligible for total knee and hip replacement. And I said this earlier, but in these folks that might go on to get a replacement anyway, there's still a huge benefit for exercise, because there have been studies showing that the fitter and stronger you go into a joint replacement, you do have a better outcome. So whether we're trying to avoid surgery or we know we're going to surgery, exercise is still going to be key. And then this quote is taken from the study above, but in 2 recent systematic reviews and meta-analyses of 54 randomized controlled trials of exercise in patients with knee OA and 10 in hip OA, exercise was demonstrated to reduce pain and improve function and quality of life in patients with OA immediately after the treatment. So you do get some short-term benefits, and the benefits were sustained for at least 2 to 6 months after the treatment period. So good for short-term pain. Exercise has that analgesic effect on pain, and definitely good for long-term as our functional capacity increases. I think we can do more things with less pain. So that's going to be huge. And then continuing with exercise, I mean, going through the research, I think that was one of the cool things. It almost seems like exercise for knee OA is not too different than exercise for back pain. It's like there's so many different kinds of exercise that are probably helpful for people. So whether you want to strength train or do aerobic exercises or neuromuscular exercises, or you want to do aquatherapy, yoga, the list is almost endless. You can work with the patient on what they love to do and find ways to continue to do that with them. And I know this is an approach you use a ton, maybe not specifically in Knee OA, but like when you work with CrossFit athletes, you have that patient specific like functional scale or whatever, where they'll write down all the exercises they do in a CrossFit workout and rate how bad it hurts the problem area. And that's a good activity to go through with anyone. So like say there's someone with Knee OA that hurts in the gym. Well, let's go through everything you're doing in the gym. And, you have pain with only 2 of the 10 exercises that you're doing. And maybe we can modify those pretty easily to keep you training and not have to take everything out. So now you're still doing all 10 exercises. So I think that's a great way to handle it, and easy ways we can intervene and probably make best use of our time with the patient to figure out a good entry point to keep them doing what they love to do. And if they can't, there's a lot of other options, which is pretty cool.
Yeah, that's a good point. And I'm pretty simple and, basic in terms of the way I handle most folks, regardless of the pathology. What I will say is that arthritis is no different, right? So if I have a patient that likes, let's say, powerlifting or running, one of the thoughts is like, oh, wow, they have arthritis. We have to treat this differently now. This is more serious than a quad tendinopathy or patellofemoral pain or anything else. And generally speaking, very, very similar. I've certainly had CrossFitters, powerlifters with knee arthritis, shoulder arthritis. It's basically like, okay, what things kind of bug you? It seems like snatches hurt me. Okay, let's back off of snatches. Let's give you a few things that will give you a similar training effect. Maybe we focus on cleans or swings or something for the time being. Maybe modify your squat stance or something on those lines. And in a lot of cases, things just get better. I've had patients that had pretty severe shoulder arthritis, right? And I've seen the same in the knee, right? But the case in kind of in my head right now is a CrossFitter, very high level, competed the game several times, and as a master's athlete, and went to the doctor. Doctor did some imaging, clinical evaluation. You have shoulder arthritis. There's not much I can do. Sent him to me. We basically treated the shoulder. I did some like soft tissue work, joint mobilizations, modified all his lifts, strengthened the shoulder, progressively worked back to all the movements he used to hurt. And he had 0 symptoms anymore. And this is a person that had pretty severe shoulder arthritis. So I think sometimes the thought as a clinician is like, oh man, this is more serious now. I need to change what I'm doing. I need to back off more so. Sometimes you don't have to, right? I think the big thing, one of the takeaways with all the osteoarthritis talk that we just chatted about is that you definitely want to keep people exercising as much as possible. It's a big, big problem when folks stop exercising, and that's going to perpetuate all of the problems. So you want to maintain their fitness as much as they possibly can. And then as they start to improve, we're trying to get them back to their normal fitness program as much as you possibly can. And don't assume that someone's going to be much more limited because they have osteoarthritis. And hey, they may be. Maybe they really have to modify that squat for their foreseeable future because they do have some pretty bad pain or disability. But I wouldn't assume that from the get-go or change what you're doing just because that person has a diagnosis,
Mm-hmm. It's so interesting because it's like the simplest treatment strategy, but it's also like an expert level treatment strategy. It's like you think you got to do all these crazy things, but you really just find the best modification for the person. And it's like,
I know.
You keep them doing what they're doing, but it is hard to get to that point, I guess.
Sometimes I feel like stupid. I'm like, I'm just doing the same thing over and over again.
Yeah, but that's it. That's the magic, is like keeping people exercising because they don't know what to do. And I think most people are either going to keep doing the same thing till it hurts more and more and more, or they just stop everything and they don't know how to find that middle ground of like pulling back. So I think that's where you could learn a ton on the fitness pain-free certification.
Whoa,
Plugging it. It's
Love
so
it.
good for that type of thing specifically. So sweet.
No. Thank you, Kevin.
And then the final thing here, education wise, I think something we can easily do as physical therapists that I know we all feel like a little awkward doing. It's hard to talk to patients about their weight and their diet. But I think, whether as a clinic, you just give people pamphlets on information or something like that, This is one of the guidelines that I think is pretty good. This is for a guideline for nutrition and athletic performance. And it just talks about that. It talks about dietary intake for athletes. It gives you some idea on figuring out caloric intake, figuring out macronutrient intake for athletes. So that's the top one. It's a position statement. And, we're not dietitians or nutritionists, but I think we should be able to make broad recommendations and not be afraid to. I think you have someone with arthritis, you just say, it doesn't have to be someone who's specifically overweight, but you just say, if you have any questions on specific diet related questions, I can give some general advice. And if you need more in depth, I could refer you to a dietitian to try to work on this, because this is an important component of your management. And then also, I think the dietary guidelines for Americans, it's not perfect, but it's really good recommendation. And I think if most people followed it, the thing with the guidelines is they seem to always get trashed a lot because everyone's so obese. But I think the big problem is people don't follow the guidelines. So they're out there, and as PTs, we don't need to know every dot and period on them. But I think we should be able to summarize them a little bit and give our patients some recommendation and have a good referral source for a nutrition and dietitian. But I think we shy away from this a lot. And I know I'm guilty of this, because you don't want someone to feel awkward because it's clear that they're a little overweight and this is something that we think would help them. But I think it's our probably professional responsibility to approach it in a kind of nuanced way without making them feel bad, but let them know that this is probably an important piece of their journey of feeling better. So I think that's important stuff too.
Yeah, I don't know. I kind of feel similar to the dietary interventions as I do about like talking about reds sometimes with some athletes. And both are, you're giving recommendations about food, which is a little bit tough. And if you don't have the knowledge, it's fine to refer out. But I do think you're kind of doing a disservice with not addressing it, particularly for someone like reds, or osteoarthritis. Like, that's one of the main things we know is going to create problems for you if you don't get this figured out, right? So that's tough. I think the other thing that we can do as physical therapists is just encourage folks. Just because I don't know that we need to know everything about dietary recommendations, but if we at least be that person that brings it up and also encourages folks to try to get some help and kind of work on that, it's beneficial. At the end of the day, it is funny that people kind of bash the dietary recommendations as like, the reason why we're overweight is because the recommendations are bad. I don't know about that, because if you just ate just broccoli for the next week and 0 pizza, hamburgers, potato chips, you'd probably start losing weight. And people have an idea about what's going to be better for you and worse for you. We're just horrible at implementing it. So sometimes I think it's just accountability, coming up with a plan that works for the patient and just encouraging them to do that. So now you have some basics about the rehab of knee osteoarthritis. You might want some additional information about treating the meniscus, because guess what? They behave very similarly, and sometimes those treatments are a little bit different. So we have a video for you. It's going to be above Kevin's head, where we go over what PTs need to know about meniscus injuries. Click on that and we'll see it on that one.
If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain-Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.